Hello and welcome. The Pacific Business Group on Health and Renaissance Health hosted the IOCP Summit, Sustainability Academy and CQC Leadership Training on May 28th and 29th, 2015 at the Hotel Palomar in San Diego. Medical group leadership, program management, and direct care team staff came together to share work to date and discuss the strategies on sustaining complex care initiatives going forward. We encourage representatives from executive and clinical leadership, program management, and direct care staff that have contributed to the success of the Intensive Outpatient Care Program. The two-day summit included open discussion, perspective sharing, leadership panels, and interactive dialogue among medical groups, PBGH, Renaissance Health, and the IOCP Clinical Advisory Committee. The agenda included accomplishments and sustainability work of the IOCP Collaborative Community, program outcomes, trends, and impact across organizations, discussion of sustainable progress in programs, teams, and individual care team members, innovations for measuring value, insights on sustainability and entrepreneurship, perspectives on future opportunities, and including commercial and accountable care organizations, networking and planning for ongoing collaboration.
Welcome. Good morning. Thank you for sharing time today. As Lisa said, this is sort of the culminating event of, I think for many of you, what's been somewhere between a 1 and 3 year journey, which is a part of a longer journey that you're on as individuals, as organizations, and we were happy to be a part of that, are happy to be a part of that today. The primary purpose of gathering, I think, from our perspective across today and tomorrow is really to gather. It's that community part that we value and that you've told us that's important to you all. And so we've created a forum, a format that allows for that collaboration to continue in this room and then hopefully outside of this room. So mainly to gather for the purpose of gathering. And when I think of gathering, I think of sort of personal gathering. Like when I use that word, I think it's at a personal level. And it's one of the things that really has occurred, I think, across our time together in this IOCP is that personal individual relationships have been formed, but also personal organizational relationships have been formed. And that's pretty neat, actually. Organizations tend to form relationships at a different capacity. And I think when you kind of come together for common purpose, it's really neat when you see that sort of start going into that gray personal zone of organizational collaboration. And so that's neat, and we're going to continue that today. Today we'll be more focused on what we've all been working together on called the Sustainability Academy, that longitudinal piece around actions, really driving towards processes and doing intentionality in your organizations, which you guys have done an amazing job of. Maybe an hour or so, hopefully in a discussion format, to share with you our observations from the longitudinal action community, what you all have done. So in a way, it's sort of sharing with you what we've seen you done and our observations around that. And then we're actually going to bring a few of your peers up to the front of the room to share at more specificity how they went about their processes inside of their organization. So some of the focus will be outcomes and accomplishments they've had, but most of the discussion will be about how did you do it? How do you get sort of hardwired processes towards sustainability? Because the outcome we're looking for will constantly be changing. The actions we're doing will constantly be changing. How do you do them in deliberate, intentional ways? That's a hardwired process. That's something you can get really good at as an organization. And so we'll be focusing on that. We're going to take a different look at measuring value. We've all talked about in a couple different formats how value can be measured. And we're going to look at it through sort of the lens of innovation accounting. And we'll pick a few areas and go kind of deep. So it may be physician engagement, it may be patient engagement, whatever you guys decide we want to talk about in that. And then we'll go deep on sort of how you do innovation accounting. It's a challenge that we're seeing nationally. There's discussions across the nation of what's the ROI, what's the value, what's the financial return. So how do we do that when we don't have a long period of time to wait to find that out, or we don't have thousands of patients that we can measure at a single time period? What's sort of the innovation mechanism around that? So we'll focus on that discussion and then move into maybe the one that I think is most important overall on a day-to-day basis, this notion of sustainability at the team level. We talked with the care coordinators about sustainability at the individual level in our academies in March or April. And we want to rise that to, how do you define sustainability from a team perspective, not at a kind of an outcomes process perspective, but if you think of individuals and burnout, what sort of team and burnout? What's team and sustainability around that? What does that mean? What are the mechanisms? What are some things that we can do to have resilience? And maybe a lot of it's around that word resilience. Whatever you can do or dream you can do, there should be a do there, begin it. Boldness has genius, power, and magic in it. While that seems sort of this fairly lofty statement, it also, I think, speaks to the purpose of why we started about 6 or 8 months ago, the Collaborative Longitudinal Academy. This notion that the first thing we have to do is design what we want to do, to think about what we want to do conceptually. What is it that we want to do? And we actually asked you to do it through a problem-focused approach. What's something that's a problem or a challenge, and then how do you convert that to actions? And then kind of a go forward from actions. Very similar though, whatever you can do, whatever you can already do or you dream you can do, you want to do it, begin it. And then you hear us say often, the beginning is now. And so some of the things that you'll hear me say today, or Jonas Goldstein, my colleague, say a little later today, will have that theme to it, which is the way to be sustainable is to always be moving, right? It's always kind of action. If you stop moving, if you say we're there, we reached our destination, you won't be sustainable. You'll actually just be out of date very quickly, right? So always moving. It's and always thinking the beginning is now, right? Today is the first day of what we're doing as an organization now. And then taking a bit of risk. And the ask is, within this boldness, to emerge out of the fellowship of the miserable. They influence us a lot. They sort of encourage us to join. And it's easy to join that fellowship. And Bill Curry will tell his teams in pregame locker room discussions that we have to emerge out of the fellowship of the miserable. There's a new sort of sustainability fellowship that's emerging. And that's sort of the inspiration as we think about the always moving, the always being active. It's, another sports analogy. I'm coaching a bit of baseball right now and trying to get kids to learn about the infield creep. It's when you're on the infield. You should not be, in the old days, actually, when I was taught baseball, we stood like this, and it was A, batter, 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 A, batter, batter. And actually, the right thing to do instead is to get into an athletic position, and as the pitch is being made, you're sort of moving forward. You're always sort of moving forward. And then what we watch, and we actually ask our kids after every play, did you move when the pitch was made? After every pitch, everybody should be moving. And when the ball moves, when a hit is made, even if the ball goes to second base, all 9 players should be moving somewhere. The catcher should be standing up, getting ready to either back up first base or get on home plate. The third baseman's moving to third in case that happens. The shortstop's moving to second. The second baseman's fielding, throwing to first. The right fielder's backing up the second baseman. The center fielder goes diagonally behind the shortstop, so if a throw needs to come that way, they're backing that up, right? Everybody's moving all the time. That's the right way to do activity. That's sort of the right way to be prepared for success. And that's, I think, what we are trying to inspire in this collaborative longitudinal activity, action community. We picked actions, but really the inspiration was around the process, the constant movement, the constant activity, the leaving and emerging out of it. And here's sort of what you guys sort of taught us through that process. So we say from a common understanding with shared experiences. So 25 large progressive medical groups, pretty significant groups across California, Arizona, Idaho, Washington, Nevada. Pretty neat, multi-state set. Diverse in terms of whether you were integrated health systems, you were IPAs, independent medical groups, and then a pretty wide spectrum between your care management histories. Some of you have been doing care management or case management or some form of that for 20 plus years, and others of you started at IOCP. That sort of led your organization to go in that direction. It's a pretty diverse set, and yet what was interesting to me around that is within that diverse set, the problems, the challenges actually started coming together as commonalities. So they present in custom ways, but they're pretty common, the things that you guys worked on and thought were important. Different sizes, market positions, the reason for you doing this work, strategic context, sort of varied by organization and where you were going to take it, varied. And then we were within this sort of framework. One administrator, PBGH, with support from the CMS, CMMI, and then you were asked to have some guardrails in terms of your model to create consistency, fidelity around the model. You were allowed to have some flexible local adoption and pretty good flexibility, we believe on that. And then we brought you together across the first couple years in CQC, sort of the leadership community, and then across the last 8 months or so in a different format, the Sustainability Academy, this notion of action and sustainability. And we asked you to collaborate and really innovate within that collaboration, asked you guys to innovate in there. So the way we organized it is we asked you to sort of think about common focus areas, and those emerged, and we'll talk about those and sort of hear if you guys still think those are the same common focus areas. When I get to that slide, think about that as I'm talking, whether you agree these are still the common focus areas. We did sort of strategic private tables. We had care coordinator events, we had medical director events, and we had leadership events. And so in a way, kind of having private conversations to hear about the changes that are going on at each of those stakeholder positions. And then we created sort of distance learning opportunities, or really you created them. We asked you if you would be able to join in groups of 3 or 4 and had some pretty robust conversation on many of those webinars. And it was neat to hear the progress groups were making, and I'll come to the progress in a second. The ask was to be agile, constantly be innovating, rethinking, reflecting, refining, sort of that agility. And then do it in the context of action plans. Do it in the context of what you want to accomplish and how are you going to get there? What's that progress? And then as we start transitioning to this formal end of our grant period, the question emerges, well, how do you keep going? How does that sustainability continue? What are the actions that you continue? How do you assess your progress? What are your future opportunities and directions? And we'll talk a bit about that tomorrow, and would love to kind of hear your thoughts on that. Where do you go next? How do you expand the work you're doing? Build on what's working, refine to get better and better, and then look back in a reflection both at an individual level and at a process level on that. So that's sort of how we designed what we thought of as a collaborative action community, what you guys really led us to in terms of the learning process and the actions that you accomplished. As we thought about defining sustainability for complex care, the word that kept emerging was endurance, sort of this notion of what's the enduring qualities of your program. What are the things that you build that are going to have long-term standing, that are going to sort of have that longevity that's needed. And so building within the IOCP principles. And when I talk about IOCP principles, I think about it, I think the way most of you do, which is this organized, intentional, deliberate focus on taking care of the highest risk complex care members in our population. So that's, there may be guardrails that are put in place at your organization, but the context of, let's find a group of people who need a little bit more intensive help or a lot more intensive help, and let's build an organized care model around them. And most of you have embedded that within the existing care process, which I think is an important part of the principle. And then how do we build sort of an iterative process within that? So if we say that's the starting point and the end point, what's sort of that ongoing iteration that we do within that process? And how do we get to these outcomes? And this is going to be an interesting discussion that I want to have in a little bit, which is, what are the right outcomes? So I think ROI comes up a lot, economic outcomes comes up a lot, triple aim comes up a lot. What are the right outcomes to be able to measure the value that you guys are producing? Is it those things? Maybe. Are there faster outcomes that we can look at? Are there more sustainable outcomes? Are there other outcomes that actually speak to what you're doing? And they start talking about provider team experience, culture, process definition. What are those things that really should be part of that outcome portfolio that we look at? So I won't go through all of this. Effectively, as we see this process, and then I'm going to pause and ask you guys to kind of reflect before I go further on some of the process that you did, especially on what you think worked and what within your organization and your process, and what you think didn't work really well, because I think there's good learning in that. But we started in October, and you'll remember we sent ahead, we emailed to you a document that was meant for you to reflect in advance. We said, here, we called it, I think, initial feedback or advanced questions, and where are your priority areas? And then in November, we got together and we talked about how we drive sort of action communities and how you drive agility in your organization. And we did formal problem-solving discussions, like how do business organizations do problem-solving, and how can you kind of carry that back, and how do you decide what action steps you should do as an organization. And then we asked you actually at the end of that day to spend a couple hours in small groups trying to identify what your action was, what your challenge was, root cause your challenge, come up with a single challenge item, and then work towards developing actions for that. And then you guys went back to your organizations and continued that process. So really from December till April, there was a series of work that you were doing on the action processes. And what actually emerged in some cases was pretty tight following, linearly following the action process around a couple actions. And then in a lot of places what happened was you started incorporating other challenges that you needed to work on into that kind of process work. And that was really neat to hear when you said, well, that was the action we identified at IOCP at the kickoff summit, but as we started thinking about it when we went back home, we actually think there's these 4 other things we really need to be working on. And that's what we're going to spend our time doing. And we had sort of some intervening sessions, a medical director summit, a managers academy. This is my least favorite title, Care Management Managers Academy. For a while, I think it was Care Managers Academy, which was even more clumsy. But, and then we did an advanced academy series for the care coordinators, as I mentioned. And then sort of here we are, the final IOCP summit. As we talk about it, I think you guys have shared a bunch of examples of sort of the emerging strategy that needs to occur. And so we'll come back to deliberate for a second and say, well, there is a role for deliberate strategy. So there's a role, as we said, a starting point, as long as you're open to the emergence that will occur. There's also a role for deliberate strategy in building a deliberate framework for how you're going to solve problems in your organization, how you're going to learn and reflect. So you guys just shared an example of how you learned and reflect what the value of embedded is inside of your organization and how you might redefine that and actually give people more of a sense of team than had you actually gone with an original, sort of more traditional definition of embedded. But that process by which you arrive there is, I think, something that has a good value to be deliberate, to be something that you embed, not to use embed again, but embed inside your organization and say, this is what we do, this is how we solve problems, this is how we reflect on the work we're doing, this is how we know how we're doing while we're doing it. And having sort of iterative cycles built into a deliberate process, an intentional, as Lori used the word, an intentional process. That's sort of the importance of where deliberate comes in. And I know we just spent a good amount of time, a good amount of sort of real estate on our agenda for this, but it's one of the most important parts about sustainability is this idea of deliberate strategy and then emerging information that arrives you to emergent strategy. And ultimately, the stuff that ends up when you do look back moments, when you stop and say, what did we just do from there to here? The emergent strategy is largely what drove you to it. You set up a great framework, but then your ability to be agile and react to new information, that emergent strategy and the intentionality in the emergent strategy is really, really important. So we spent a bunch of time on it. Want to make sure that sort of is one of our take-home messages. I should say before I go to the next slide that if you see me sort of looking with good posture or incredibly thoughtful when one of you are speaking, a lot of that is because I've been told that when you're speaking, the cameras are going to be on me. So I have to look really interested in what you're saying. So I'm not that interested in what you're saying. I've just been told that I need to focus because the cameras are looking at me. I'm going to switch to a slide that you've seen before that sometimes is scary. It's probably become familiar, so less scary now. This is what you guys told us the challenges are at the beginning, and we sort of have size and shape that speaks to the relative importance of these challenges. What's impressive about this is they're pretty far-reaching, right? I mean, everything from billing and cost to technology to how do we measure impact to enrollment, patient selection, patient engagement, measuring data. You can see the big words that started emerging. Those are the ones we're hearing a lot from you all. I'm going to flip to 2 slides from now, and I'm going to ask you if those are still the ones when you started curating down. So this was sort of everything you said. These are our big challenges. And gosh, we could spend day-long seminars on sort of measuring impact, or how do you do enrollment, or legislative things going on in healthcare.
big problems. This is what makes our work really exciting and the opportunity really rich and also really hard. We asked you to curate that down a little bit, and we said, so what are the things in order of priority, sort of the 3 big sustainability issues as you look forward and say, for my initiative to be sustainable, what are the things we really got to get good at? And so you started narrowing it down to team engagement, measuring impact, enrollment continued to be a big one, selecting patients, staffing and training, which we've had a lot of discussion on here right now. Employer relations had some mention. ROI comes up, socio-behavioral needs, there's a smaller mention on this one. But these became the more narrow set of the items that you said we really need to work on for us, or focus on for us to be sustainable long term. We ended up breaking it into sort of 3 categories. And I won't ask you to reflect if you still think this would have been the category you would pick kind of 6 months later. But at the time, the 3 big categories were our patients. And within our patients, we talked about identifying the right patients, enrolling them, and matching our care to the patient's needs. So pretty big, comprehensive topic. Our team, so the whole staffing model, integrating teams, engaging teams. In that, physician engagement was part of it as well. So some of you sort of made that rise up as your number 1 for physician engagement. And then capturing our work. How do we measure how we're doing, and how do we communicate our value? And we've had some emergence on what this means, even across six months. I think when we started talking about capturing our work, people were thinking about triple aim. That's sort of where that conversation went. When we looked at the sheets you created, they were focused on how do we prove out triple aim. I think it started opening up a little bit to saying, well, how do we actually measure how we're doing while we're doing it? And then how do we communicate it? Part of capturing our work is being able to take what we've done, assess it, distill it into the insights, and then share those insights out. That we're not done by just measuring. In fact, measuring, if we don't show value to somebody else, is sort of just for ourselves in our learning process, but it doesn't sort of really become value until we're able to communicate that out. And so that's that category sort of began. And then we did what we call collaborative routines. And we did the launch exercise, the peer review. I'd really hope that we can find ways for you to continue peer review even outside of these formats. So if you have organizations that you work with, find ways to peer review with them. Getting outside of your building is really, really important to know whether what you're doing inside the building is effective, whether that's sort of the right direction to go. And then sort of pooling perspectives from within your team, having sort of a larger team effort on that. And sort of, sometimes we even talked about it as then using that as a possibility play out. So having what your strategy is before you actually do it, having kind of a role play out on how that's going to work. And then focusing on action, assessment, refinement, and then the discipline that we've been talking about, that discipline on the process improvement. So when we say we're doing process improvement, what's your method? What's your mechanism that you guys do it on? And our panelists will share how they did it. You each will probably have a mechanism by which we did it. On our, and I want to reinforce these webinar series, we had one that was around action issues, and the real ask to you was, what are you really doing? So you picked a challenge and you picked some action steps. How are you really doing that? How's your kind of build, measure, learn cycle on that? And then the second was on measurement strategy, and we have an hour in the afternoon that we're going to spend time talking about that. How do you get to measuring how you're doing while you're doing it? Here were sort of the challenges that you guys said were the big ones. And I'll read the bold print here, and then I want to pause and say, do you still think these are the big ones? What else would you add up here? So enrollment challenges, finding the right patients, increasing engagement, matching care resources. That was the notion of, based on what a patient needs, not having one size fits all, actually customizing the care resources, having the right staffing, having care team engagement, and maybe with an emphasis on physician support, measuring impact, communicating value, and within measuring impact, what rose outside of it was data collection. So how do we actually collect data was a problem. And then how do we create business models around the work we're doing? Do these still sound right? How would you rank order if you had to, the top 3 for you right now? Are there new ones that have come up? This is sort of your reflection to us. Are there other ones that you say, gosh, now that I think about it, this is what would emerge? Or what are the first few things that emerge for you at this point? Here are things you guys did about the problem. So this was sort of the challenges you all mentioned. and in good fashion, not stopping at the challenges because I want to be uplifting. There's a ton of work you've done in sort of 6 months to start moving against these challenges. And so what obviously happens when you get good at certain challenges is new challenges emerge, and you guys are sharing newer challenges and saying, well, now this should be on the list, and this one's a big one. But a ton of work, accomplishment done in this look-back moment. So we often say at RenHealth that we wake up and what we want to do is sort of shape markets or shape organizations. But what we mean by that is that we want to be able to fast forward 3 years and look back and see what's been accomplished. We want to have seen progress, because in the moment, in that day, and the next day, and the next day, very hard to see progress. So when you start at the end of each week and say, what have we accomplished? Sometimes it's pretty small steps. They aggregate up to some pretty meaningful things, and you guys did that. You talked about enrollment and a lot of work around refining member selection, I think, in this room. A lot of work around tapping new sources of members, creating care teams that had bandwidth for enrollment. I think early on in the very beginnings of this, a lot of times we thought enrollment could be done just as an add-on inside of work people are already doing. And it's actually probably hard to do that way. There isn't existing bandwidth. Working to get physicians to be involved more in the process, focusing on new metrics. What's sort of our volume? What's our milestones? Similarly, for each of these, you've done things. Care team engagement, we've heard stories of good marketing campaigns, sort of internal marketing and communication campaigns, finding early champions around the work, focusing on practice managers. That ended up being sort of an emergence where we said the goal is to get physician engagement, and the recognition was we have to get practice manager engagement. That's how we get physician engagement. And then I actually talked to some of my colleagues who I said just show up and do what the schedule says every day, and I sort of pressure tested what they mean, and they're like, basically I do what the office manager or practice manager tells me to do every day, which is in reality how that schedule sort of gets developed, what the guardrails around that are. And then having, again, metrics, reporting to care team members, so letting people see, having transparency around the metrics. We talked a lot, you guys already did, about additional staffing models, non-licensed staff. A ton of work across the last year in this room done on non-licensed staff and being more inclusive of them. You'll remember in some of our meetings we actually had panels where we talked about kind of the groups that were leading and progressive in terms of having non-licensed staff. Now I'd say most of you are using non-licensed staff in some form, and that's become really kind of exciting and encouraging to see. Integrating behavioral health, we're hearing sort of emerging ideas like Phil shared from Polyclinic around how you integrate behavioral health in efficient ways, because another sort of challenge in the moment when we need behavioral health. What's your overall kind of model organization? How do you staff? How do you troubleshoot as you move between care models? How do you do communication within your organizational structure, independent practices, and communication with them? I know St. Luke's did a lot of work on that in terms of the new, as Aaron described, the new group that was coming on, and how do you communicate out to the physicians in that work? And then this one, I'd say when we started, I'll step back two plus years ago, the measurement was largely around this triple aim notion. That's sort of where the discussion went. When we started 6 or 8 months ago on the Collaboration Academy, you could already see progress having been made. We were hearing kind of emergent measures. And I think today, you guys are moving into, well, gosh, what is sort of the innovative measures we should be using? What's the real time? How are we doing while we're doing it? So a lot of progress on that, and some data starting to come in. Rob will share some data tomorrow. I know on the leadership calls, PBGH is sharing additional data with each of your groups. And then this one's actually, I think, both progress made and new challenges emerging, as Tori described as well. So progress made around business models and value, and I think good signals from market, more payers coming to the table for value-based contracts, CMS saying that they're going to convert 50% of their payment model over to value-based contracts. With that, though, I think what emerges is an increasing feeling of we're in two boats and they're kind of drifting, and which one do you jump in, or how do you kind of manage that split that's occurring? Because there are a couple of different payment models at the moment that we're working within, and different contract types that we're working within. You guys have done a great job figuring out how to work within different contract models within a single organization, because most of you have more than IOCP going on. You have other risk-bearing, upside-downside type models emerging. what we've seen and what we continue to encourage you to do, the way you've addressed these challenges, and the way with intentionality you did it was you said, there's a challenge, I know something I got to solve, I have to do some kind of solution design. Once I did solution design, I need to measure whether that solution worked or not, right? I have to know whether what I just did worked or not. And so you have to have a pause point, a baseline, something that says, when I had the challenge, this is the issue, now I've measured it, and then I learned from it. This is a little bit of, you know, I used to think, somebody said this earlier, I used to think, then we learned a bunch of things, and now I think. And so based on now what I think, I have new ideas and insights, maybe new hypotheses, and I rebuild. Whoops, pushed the wrong one. I rebuild. So that cycle, if I think of something to make deliberate inside your organization, it's that cycle. The sort of last hour and what you guys have shared has been really about this. Make this a deliberate strategy. Build, measure, learn. Build, measure, learn. You'll find when you go back and look at your process and your progress, the more that you've been able to be deliberate about setting up what you build and what you think the milestone is, you're almost defining that cycle at the build point. You have to define what you're going to measure to know if it's working or not. So this I can't emphasize enough. In some ways I'd say if you could, it's right with that deliberate emergent strategy, but it's the part of the emergent strategy. So I said a deliberate framework, but this is the framework that drives your emergent strategy. Does that make sense? That's sort of a part of a deliberate framework. In the next slide I sort of went over the build, measure, learn, what that really means. So what did you do? What was the thing that you tried that then you measured and you learned from that? And a few of you already shared some examples around that already. So the innovation cycle, repetition is imperative. So we're on that slide that says through the innovation cycle. So continuous process action, you guys know this, this is what we've been driving towards. This is what you guys have been doing and sharing and telling that you do. What works really well, and Lori used the word intentionality. I think having intentionality and then transparency, and then a new word that we'll include here, and so a point of emphasis, is inclusivity. And that's moving from sort of a top-down approach, whether you're the top or you're not the top. There's this feeling in healthcare historically around somebody decides something and then everything else sort of has to happen. I think somebody back there said leadership will come up with something and then we have to try to do it, and it turns out it's not right, it's not doable. And that's because we weren't inclusive. I bet you some folks could have already told leadership that wouldn't work, and here are the reasons, and so let's sort of build knowing that information. So remember the inclusivity when you're doing it. And then remember rapid cycle. But let's pause for a second on this rapid cycle. Healthcare is rapid cycle. And the reason it needs to be rapid cycle is because we've largely paused historically in healthcare because of first do no harm, right? So we have to prove something before we can go forward with it. And we repeatedly have to prove it. In fact, Alan, you and I were talking this morning how every time we try to do something on a process innovation, they sort of say, prove that works again. And yet for beta blockers preventing MI, it's proven. We don't have to prove that every time. Like when you prescribe a beta blocker, you're not sort of having to defend that prescription. It should be even less of a burden when you're doing process innovation. It is harm-free work by and large, right? Process innovation, the kind of process innovation you're doing is adding care largely. It's largely harm-free innovation. And there's this emerging understanding in healthcare of needing to do harm-free innovation. And yet there's a tension because the harm-free intervention comes back to, well, is it worth it? Is there an ROI? Does it improve quality? And what we have to sort of drive a culture in our organization of is willingness to do those things in rapid iterative cycles in order to get to that result. What's sort of the rapid cycle within harm-free innovation to get to that result? And actually, we think of the work you guys have done and what I was able to show just prior to when the screen went blank as a proof point for that. Look at how much you accomplished in either 6 or 8 months, which I think was a ton, or if you go back 2 years. That look-back moment, most of you, maybe take a moment as you're going through today and tomorrow and just stop and say, if I were to look back at what I personally have accomplished and what my organization has accomplished in the last couple of years and even the last 6 months, it's pretty significant. It's really, really significant what you guys have accomplished. which sort of leads to, well, what's one of the most important factors in accomplishing that? And so the slide would look like this. It would be pretty on the screen. It's blue and has nice color, but it's resilience. Do you guys know the grant project? This was a Harvard students studied over longitudinally, so 230 Harvard grads from 1941, 1942, funded by Mr. Grant, who had like dime store fame or something like that, and said, I want to study sort of people's health and happiness across a lifetime. And so he funded this work, and these 230 or so Harvard students were followed all the way until, I think they're still followed, but there was a report out a couple years ago, a published report by the principal in the study, as well as sort of an Atlantic paper, white paper sort of thing that's actually pretty interesting, more consumer friendly in the write-up. And what they looked at was, of those folks, so it's the 60-year following of them, what were sort of the important factors within health and happiness? And what I trigger on is the happiness part. Actually, the health part was interesting, but more predictable. The happiness part, so some things started to emerge, and then I'll land on what emerged the most. But the way they tracked it was every year or every 6 months, they interviewed people about the past year. Let's say every year for our purposes here. Every year they interviewed those individuals. They found them. They found ways to get to these people. They all got interviewed again. Social workers interviewed them. Principals of the research interviewed them. And they asked them about the previous year, and they asked pretty specific questions about how they've made progress forward, what has happened in their health, what has happened in their life. And the usual things happen, right? I mean, some people were successful. Some people, by certain standards, sort of the metric of financial wealth, there were people who were successful in that. By the metric of sort of good families, people who were successful in that. There were people who had challenges along the way. They had deaths of spouses, or they ran into alcoholism, or you know, the things that happen in life. And things that emerged as really important to happiness was relationships. And parental relationships was important earlier in life. What was really interesting is later in life, the things that emerged in terms of relationship later in life was actually relationships with the generation younger. So actually being in spirited relationships with the generation younger. Sibling relationships mattered a little bit less. So that was interesting to me, sort of the nuance within relationship that was important. Turned out wealth, financial means, was important till about the mid-30s and then stopped being important. So actually to happiness. Early in life, financial means was pretty important, and as you got later in life, as you sort of tried to sieve out what happiness was, distill that, it became less important to actually be financially wealthy. And that actually spanned the whole spectrum. Vices led to unhappiness, so alcoholism was sort of this trigger around unhappiness, and there was some more detail on the causality of that. What I thought was the most important, and actually has influenced me quite a bit, and not the only place you've probably heard this, but really important, is that all of them, every single one of them, at some point had multiple deep hardships in their life, just as all of us in this room have. There have been times in our life where we've said, man, we're close to bottom. This is really hard. Our own definition of bottom, we're close to that definition of bottom. This is one of the 5 worst times in my life. And all of them had that. They had really bad things that happened to them, whether they were self-brought on or something they couldn't have controlled. What emerged amongst the happier was a longitudinal resilience. So one of the characteristics that rose up amongst happy people was resilience. And I think about that as we talk about, and we'll talk this afternoon about resilience around teams and sustainability. But I think about that we just talked about challenges and we talked about solutions and the amazing accomplishment you guys have done in solutions. And what was the result of that amazing accomplishment? Well, new challenges. Now you're like past that challenge and you're like, now I'm actually at a harder challenge. We've actually reached tension points that are even tougher to break through. And those that will emerge stronger and happier are the ones that are resilient, the ones that actually have the ability to continue in sort of that adversity to try to figure out and solve the problem. It is sort of emerging out of the fellowship of the miserable, what we started with, right? That the folks that sort of say, man, this is hard, all right, I'm just gonna take a break, or I'm gonna go the easy route, or I'm just gonna decide that this is my bottom and it's gonna be really hard to sort of evolve out of that. And the ones that end up really happy, sort of that group that ends up happy, and if the definition of success, one of the definitions is happiness, and I would argue that's a really important definition of success. Resilience is a characteristic we need as individuals, as teams, as organizations, and it's going to be really important as we continue through today and tomorrow to hear sort of about that resilience, because as you go to the next slide, what we do know is that we're constantly going to be changing. Things are shifting. Your challenge is shifting. The contracts your organizations have is shifting. The willingness and appetite and leadership is shifting. Lots of changes that are happening. Even in this room, I'd say, many of you have had leadership changes across the last 3 years that we've been together, 2 years that we've been together. We know that there is uncertainty, that there is going to be uncertainty, there's going to be moving targets, and ecosystems don't evolve in perfect harmony. We wish it was predictable and that it was, once we've set a good sort of composed piece, that it's going to continue that way, but it's not. It's going to require us to constantly be changing, sort of that resilience factor. And so what we spent the last hour really focused on, a little over an hour probably at this point, and you guys have shared, is that once is not enough. It's this constant iteration. It's a constant movement. Everybody's always moving, right? It's that infield creep. You're always sort of on your toes in an athletic position. If you're not on your toes in an athletic position, you're likely not going to be fast enough when something moves. It's going to get by you. If you were doing Taekwondo, my son did Taekwondo, and what his instructor would say is that if you're not in an athletic position, you're going to get knocked down. And it's true. It's absolutely true. In fact, in his studio, the teacher would kind of be walking around during the teaching position and just push people, and they'd fall. They would actually just fall back because they're not in athletic position. He asked of them for an hour, every time you come in the studio, be in an athletic position the whole time, because otherwise you're going to get knocked down. And so that's sort of what we're asking ourselves in this model of uncertainty, in a time when we don't know exactly where things are going to be going. Get in that athletic position. In November, we talked a little bit about, we don't know what the rules of the game are going to be in a year, in 5 years. We do know certain things that are going to be important. Let's start building those things that are going to be important. Problem solving is going to be important. Deliberate, sort of intentional processes. Collecting data is going to be important. Get good at collecting data. That's going to be important. We could probably name out the things that are going to be really important no matter what the rules are in 5 years, because that's going to be something that you're going to have to be really, really good at. And that's going to be your athletic position. If you can find those things that you have to be really good at, no matter where we end up in terms of payment model, no matter where you kind of organizationally end up in terms of partnerships in your markets, what are the things that are going to be really important? Build those things. Build those things fast, rapidly iterate, stay in an athletic position, keep agile, everybody moving all the time. I appreciate you guys sharing. You shared in this discussion, as we planned it out, we didn't know how much collaborative conversation would happen. It's just impressive to hear the amount of thought that you're putting into what you're doing at your organizations, how you're measuring it, and really appreciate it, and actually applaud you guys for that. It's really a tremendous group of organizations and individuals in this room.
My name is Jonas Goldstein. I lead strategic research at Renaissance Health. One thing that we've heard from you all throughout this community is that you enjoy and you get value out of when we put together structured conversations with peers from medical groups within IOCP, with leadership from within medical groups in IOCP. And we've set up a panel this morning from 3 groups from within IOCP, and we've asked that they share with us, sort of in the theme of the day of focusing on process and sort of iterative cycles of improvement and intentional structure around how we approach processes. We've asked that they share a little bit of their experience over the last 2 years and over the last 8 months in this intentional sustainability community, the experience of their organizations, building process within IOCP and thinking about program sustainability. So we have 3 guests with us today. First, we have Phil Lilich from Polyclinic. Phil is the ACO Director of Health Services and also the Director of Care Management at Polyclinic. We've had the opportunity to work with Polyclinic in a couple of different settings, and it has always been a pleasure. You know, they have good passion for measurement and also for standardization. I think you guys bring a particular touch for standardizing processes that can be standardized. So really happy to have you join us today. Phil's joined by Dr. Charles Payton, who's the medical director at Epic Management and Beaver Medical Group. We've been joined by Dr. Payton in the past at the community launch in November. Epic shared with us an ROI tool that they developed that's actually available to you all on Box. Happy to have the Epic team share with us today again. Our final panelist is Tori Starr. Tori is the Care Coordination Executive at Sutter Health Sacramento. Sutter Health is kind of a different type of organization, different organizational context maybe than our other 2 speakers, and was one of the groups that, as Pranav mentioned, sort of brought a pretty sophisticated care management program into the IOCP experience. So really interested to hear sort of your experiences compared to the other 2 groups as you've formalized process. So I will go ahead and maybe I'll ask each of you as you introduce your thoughts and begin to share your thoughts to say a little bit more about your role for the group, maybe what your role is in actual process design, process structure. As the panelists are sharing, it'd be great if we're all kind of thinking about best practices that emerge from their experience, specific questions. We want to get really concrete and really down to detail. We've heard that that's something you guys get value out of is getting very concrete in process observations from group to group. So looking forward to hearing from all 3 of you. And with that, Phil, maybe I'll ask if you'll kick us off.
So I wanted to give you a little bit of background. So the Polyclinic, we are an independent physician-owned multi-specialty medical group. And that kind of comes with its own set of challenges around physician ownership. So our path down IOCP originally was started as we needed a solution for our commercial payers. So our market, we are now at about 60% of our population is at some type of risk. So we started to build a solution for our total cost of care global outcomes contracts, and then it was a very nice fit as we participated in the IOCP grant. So our 3 challenges, we also picked challenges to share with you that help to represent kind of our evolution in the process. So the first major challenge was around physician engagement. And as the physician shared here with us, you know, our physicians kind of did practice as each site was their own wild, wild west. They were independent, sharing one roof, and we did have that culture for quite a while. So how do you engage physicians? Once, though, we had them engaged and that they accepted more of a team type of approach, that really did set the stage for future success with the program. Once we got past that, the second challenge up here really related to some of our documentation. So how can we streamline some of that? Once the panel started to get full, we had to look at different ways of actually moving forward and making things easier for our enhanced care nurses. And last is how we really structured and looked at, again, the patient population. So we came up with an acuity system. Some of the actions, again, that we took here are really related to, again, building that relationship with the physicians, building the relationships with the enhanced care team, and then with the acuity, the actions, this is setting the stage for our next improvement, which we hope to roll out, actually, wellness coaching. So, with our processes, the organization has embarked over the last 3 years of trying to implement more of the lean process. And as you can see up here, we went ahead and leveraged some of the internal processes that we were all learning to actually enhance our continuous process improvement with this program. So there's a whole list of players that we went ahead and engaged so that we can continue to improve our program, and it's worked fairly well to for our program and our success. So backing up just a little bit with the starting out in the addressing the commercial need, with our total cost of care, our global outcomes contracts, most of those contracts were written so that reconciliation did not happen for anywhere between 18 months and 24 months. So our executives were like, well, prove to me that the program is actually working and that there's actually a return on investment. So we do all of our clinical documentation and tracking in Epic, and then we developed our own database to track the clinical, the non-clinical tasks related to the program. And so when I looked at this, I wanted to make sure that we reflected our added value really in two different ways. If the patients were not engaged and the team actually did a warm scheduling of a person and re-engaged that person with our physicians, then we took credit for the average cost of that office visit. If they avoided an emergency room, we used our data and came up with the average charges of emergency room. So this way you will see, revenue generated and costs avoided to come up with a more complete picture. We layered that on top of and took credit for a portion around our shared savings contracts when it related to, emergency room readmissions or avoidance, and also hospitalizations. So that helped to sustain and build our program. And with this, we're actually sitting at about a 3-to-1 return on investment. So again, the different steps, we continue to work really close with our physicians. And the engagement piece, the organization's also going through a redesign of primary care, so this fits nicely into the value stream. So that helps with us, and it will help build some of the foundation in laying where the task and responsibility is with the MA and the physician team, and then the handoff as we build wellness coaching and develop that, so that the wellness coaches will be paired with our enhanced care RNs, so that we'll take their caseload from 125 each to probably about 250 each, because they'll be paired with an MA or wellness coach.
Philip, to your metrics slide, that was a really impressive quantity of data that you guys have captured, and an impressive amount of feedback. How have you balanced the reporting burden, sort of from the front line and from an input perspective, with getting that amount of data? Has that been a tension?
It has and was at first, and that's why we quickly got to that second challenge around documentation. So the team is with me today, and we built then our documentation and the data entry so that they were synchronized as far as the flow goes, so that the team then could get in the habit of doing an assessment. And there is always going to be some redundancy, but we try to minimize that.
And was there any feedback from the front line? Did you hear positive or negative, or is no news, good news type thing? I see 2 thumbs up from Kelly in the back.
Kelly's saying 2 thumbs up. So I think now that we've got our flow down, so that we keep revising all the time. Pranav talked about frameworks. So our general framework around the documentation piece and streamlining is we still base most of this on NCQA. Since the team also provides support to many different types of programs. So whether it's we're fully capitated for Medicare Advantage, so whether it's that business, it's the commercial business, we continue to build on some of those frameworks to give us some consistency but flexibility at the same time.
Mm-hmm. Great. Sure. Thanks, Laurie. I'm without a microphone. Oh, great. So in the back.
I believe you mentioned that with the health coach or the wellness coach and the case manager, that allows you guys to manage 200 plus patients. Just curious the type or the acuity of these patients, and does that include any face-to-face or all telephonic?
So, Great question, and it hasn't been fully built out. But that's why the acuity was our natural next step. So the goal is we needed to find a way to make sure that the enhanced care nurses, their panel size was balanced. So once the patient is actually moved into a maintenance phase and they have sustained some of their gains for 3 months, then we're going to step them down to the wellness coaching. So the RN will continue to supervise that, but the calls, the monitoring of the labs and all of that, the frequency of those calls will be handled by a wellness coach. So it'll be the team of an RN with a wellness coach that will have 250. And if you're talking about the illness burden, as far as how they're stratified, we're then looking at that population. That's what for our organization is called rising risk. So we've come up with 3 buckets. You have your high cost, high risk, complex patients. Your next band is your rising risk, and then the bottom of the pyramid is your low risk patients.
I would like to ask you to elaborate a little bit. You said a ratio of 3 to 1. Could you explain what you meant by that?
So the cost of the program is the 1+1,
Oh, okay.
and we're seeing a 3 to 1 return on the program.
Okay.
I'm wondering if you use specific criteria in order to document an ED visit avoided. We find that it's sometimes difficult when we start to look at cost avoidance as a measure. So how did you document an ED visit avoided?
We're very conservative. So the criteria that we use is the patient actually has to call the enhanced care nurse and say, I'm on the way to the emergency room unless you can help me. And in that instance, we go ahead and facilitate an instant same-day appointment, and that's the only time that we take credit for it.
Oh, that's great, because we know that these programs avoid ED visits all the time, but we sort of get into a pickle sometimes when we begin to talk about cost avoidance.
Correct.
Do you ask them to do that when you enroll them? If you ever need to go to the ER, call us first? Do you ever?
We do. If you feel you have a question and you can safely reach out to us, then we ask that you call your enhanced care nurse. And what we have found that the patients, especially for Washington and around ED access, the layman's terms, they're pretty good at deciding whether it's a true emergency. And so the nurses are not handling heart attacks on the line, but they are handling those drug reaction behavior issues and rashes. So we have avoided things that can be successfully managed in the ambulatory setting.
And I have 2 other questions. Do you avoid urgent care too, or that's not part of it?
I wish we had urgent care.
Oh, yeah.
So it's just really unique to our setting. The payers in the Seattle area stopped paying for urgent care, so all the urgent care went away. Now they're trying to rebuild that.
Oh.
So we have an access issue around and lack of urgent care facilities.
And then the other metric that you looked at, the physician visits, you were taking the money for that. Was that how you were measuring the cost savings? So if you had a visit with the patient, that you would assume that you would get that monies instead of the physician? I'm just not sure I understood
No,
that.
I'm sorry. So for that, if the patient was completely disengaged and we successfully re-engaged them with the organization, whether that was an office visit or we got them into diabetic teaching, our lipid clinic, we took the average cost of one of those visits at the different settings. And then the nurse actually scheduled the patient for them, And then we have a follow-up report, is did they actually adhere to that?
So the income, in other words, your offices are getting because that's...
We don't actually get the income, but it helps support the program.
Right, no,
Yeah,
that's
but
a good idea, actually. That's a very good idea.
it shows the added value we have because
Yeah.
we're a provider organization to the providers.
In regards to the documentation, how are you negotiating meeting like NCQA guidelines or what a health plan auditing and communicating to the physicians in your documentation? Because the physicians really want our care managers to communicate the interventions and what they're doing for their patients. So how do you negotiate those two pieces?
So that's where we're down to, we're down to 4 templates plus 2 follow-up templates. So that's where we have standardized that, and actually it's embedded into our electronic health record, EPIC. So the physicians can see that, that documentation and what the nurses are working on. So we share EPIC with the hospital system, where about 80% of our patients where their admissions occur. So even on the hospital side, they can see what the enhanced care nurses are working on.
Great. Thanks, Phil. Those are fantastic questions. Great discussion. One more. Great.
Regarding your hospital readmission rate, so patients will go to ER for CHF, COPD exacerbations. And so, with CHF, there's the CHAMP program and the guidelines, and with COPD, they have their action plan. So our care managers, of course, are aware of their disease processes. Does their enhanced nurse help them say, okay, well, as we've talked about, take your extra Lasix with your extra potassium and we'll get you in first thing in the morning? Do they follow those types of clinical disease management guidelines? Is that part of the ER avoidance?
It is not at this time. So they do provide some education, and the structure around their individual goals, though, are patient-centered. So we start with what, I'm sorry, I'll back up. They can be working on 3 issues at one time, but they have to be driven, at least the top 2 have to be driven specifically by the patient so that there's patient buy-in. That might not be a clinical disease pathway. So it isn't at this time.
Great. Thanks, Phil. Fantastic. Dr. Payton, could you share some of your experience from the EPIC team?
Happily. Good morning. A little bit of the background to sort of set the stage. EPIC is the management services organization created by Beaver Medical Group in Redlands, San Bernardino area. We found ourselves starting from a slightly different point probably than many of you did. We have a limited Knox-Keene license. We have got an HMO license, and started taking full risk for initially Medicare patients, and now in the last year and a half we've included commercial. So we've got about 65,000 global risk lives under the EPIC health plan. So besides being an MSO, it is also a health plan at this stage. Well, in taking the Medicare patients, some of you are familiar with the special needs program, and we had variably something like 1,200 or 1,500 special needs program enrollees about 3.5 years ago. One of the reasons I'm a little vague on the actual count is because the special needs programs have different plan numbers, and keeping our data people up to date on what the plan codes are for special needs was a bit of a challenge, and oftentimes we had a wake-up one morning with a new enrollment of a few more hundred people. Well, when we first encountered the reality of the special needs requirements, and this is another piece of the story that while we weren't free to adopt our own set of criteria for documentation and how you do your interventions, there was a template out there for us, an over-the-top template for any of you who have dealt with CMS and the SNP requirements. But with a department that I had expanded to include some disease management programs, but really having no nurses dedicated to the kind of complex case management per se, meaning multiple morbidities that you typically encounter with special needs, we did a dramatic shift and just said, we need staffing to do this complex case management, ambulatory case management, and we're faced with a queue of easily 1,500 SNP patients, all of whom need an assessment, and you have to do some risk evaluations and try and be prudent in how you assign your resources. Well, this is sort of a travel log of where we've been over about the last 2 years. And if you will, at the far left, that transition to 4 RNs came by retitling the disease management nurses as complex case management nurses or ambulatory care management nurses. I was tempted as I was working with this actually to draw some circles over 3 or 4 portions of this and label them PDSA activities, because we really did follow that kind of stop, pause, look at what we're doing, what are our challenges, and some of those are outlined in subsequent pages, and I'm not going to go into them in depth, but we started with RNs, and I was very purposeful in saying in California, because the law requires that a care plan is signed off by an RN, and I had this huge queue of patients that we needed to get started, that the first wave was going to be RNs, but knew that very quickly we were going to be provided an opportunity to offload some of the work of follow-up, some of the work of lower risk patients than the high risk patients that are part of the IOCP project. So you can see as we move across how we have expanded the nature of the team, both in terms of the disciplines as well as the numbers. And Carolina has been very diligent in spending time every couple of weeks meeting with the staff, reviewing what their tasks are like, what are their frustrations, the challenges that they're dealing with, and moving things about, trying to move tasks to the less costly level of tasking or of staffing. One of the points off of this slide is the monitoring of utilization. We did start very early on trying to do some measurement of impact, and one of our models was the use of before and after. The patient population that we put into case management was its own control group for the period of time immediately prior to enrollment. We had some results off of that showed that in fact we had reduced ER activity, reduced some admissions to the hospital, but I'm the first to admit that the N wasn't very large, and we didn't accommodate for other changes in the environment in terms of things that would have impacted the patient's care process. We do have urgent care. We have a lower ER utilization rate as a result of urgent care. It's been part of the nature of the group for many, many years. We did, however, make a special effort. We haven't done a lot of marketing with urgent care to either our own population or to the public, but we saw this as a time where, in an effort to manage the high-risk population prospectively, we did direct mailings and pointed out to them that we have the urgent care, we also have the nurse advice unit, so for after hours, that was another point of access. One of the things that we have been continuously doing is looking at the risk assessment of the population and Given the requirement that the special needs population stays in case management as long as they're in your medical group, we needed quickly to figure out where do you draw some lines in terms of the intensity of staffing. So we have labels of high risk, of low risk, of a holding pattern, if you will. For those who decline, CMS doesn't recognize the patient's free will in terms of the way they write their regulations. So we have to have a category for that. This is going to continue to be an area of evolution and study for us, partly because the SNP population is declining as the health plans in California move them out of special needs and into the duals project, at least in Southern California. And from the health plan standpoint, it's interesting that they see this as an opportunity to lower their visibility in terms of the audits by CMS. And we're happy to accept that, that gift of a less intense audit on their part. That'll give us some opportunities to make some different kinds of decisions. And we've had a discussion in the last few months just about the whole idea of graduation, which we haven't had much opportunity to actually say a case is closed, you're graduated, we're moving you out, we'll store your records in the archive where we can retrieve them, because most of the original enrollees were special needs. You've heard mention of the ROI tool. As much as we would have liked to suggest what we showed you was a very polished product from a few months ago, we're still working on it and still feeling very challenged by it. Whether the questions that were asked for Philip with respect to what do you count as a savings, what do you count as a cost, I'll tell you that we have, if you want to dichotomize the approach from looking at individual patients and trying to assess events that create cost or cost savings, we're taking a population view of it. In other words, where we aren't trying to look at ER events for an individual patient, we're treating the study group as a population and what is its frequency of ER utilization, inpatient admissions, et cetera. So that's a difference in the fundamental approach. And just a comment, we've listed some things that went well. I want to give acknowledgement to the staff and Carolina's leadership in terms of involving all of the staff, and others have made some comments about how incredibly productive non-licensed, non-certified people have been, and we're getting the same kind of experience from care coordinators and LVNs who are offering some breakthrough thinking in terms of new ways of approaching the patient and alternative assignments. I mentioned collaboration with IOCP groups. It really has been great for us to be part of this. And I'll also add that in terms of launching a whole area of complex case management for our group, the education, the support that has been provided by IOCP, we would not have been able to reproduce elsewhere. In fact, prior to learning about IOCP, I was calling everybody I could think of, and at one point I called Lori Colley about local referrals to see are there any organizations that are running these kinds of academies or training programs or higher education schools, and was feeling very shut out of any kind of alternatives. A couple of last thoughts. We are now working on a staff productivity report so that we can look at really what our capacity is, always trying to get the most from each level of staffing and each individual. We know that we're facing very limited resources for any future growth. But the other thing that is going to change is we will be refocusing probably away from the special needs population and refocusing on the the global risk population that we have. Now, some of the SNP for the most part is global risk, but we'll be looking at straight MA, we'll be looking at commercial, and so we are, like probably everybody else in the room, looking for the best way to use our data to identify those patients that are high risk. And I like one of the things that Phil said, that one of the bands of their population is the rising risk. I feel like I need to have a follow-up conversation to find out how he defined that, because I've been playing with it and find that much of our data is lagging so much that as they start to increase their cost, by the time we identify them, they're probably well on their way to being at the peak of their cost curve. The other thing that we're going to be challenged to do is to move closer to our physicians in terms of both the patient identification, the case identification, and the collaboration. For better or for worse, starting with the SNP population, we had a mandate. This wasn't optional for the doctors. And so as we rolled this out, we said, we've got things that we have to do that are part of our requirements, regulatory and contract-wise, and we're going to build it so that we are communicating with you, we are sharing with you, but I'll have to admit that where the interdisciplinary care team is part of the SNP model, implementing that as a way of doing feedback and interactive plan development has not been one of our great successes. In the interest of showing where we've come from, I offer this. I call it the interdisciplinary care team circa 1970. I assume because the beds, then first of all, they're in beds. Second of all, they're in the old metal frame beds that you would have seen in some of the hospitals. But I give great credit to the fact that at least there were a couple of other disciplines around the patient contributing to what was going to be done next. So anyway, thank you very much.
Going back to your travel log slide, I wonder, I saw, when I looked closely at the slide, about 5 major process redesigns over the space of like 17, 18 months, right? Did you guys encounter any fatigue as you translated some of those redesigns, some of those changes and refinements from your working group, from your team, out to the front line, out to the rest of the organization?
I'm not sure how much of this was apparent to the rest of the organization, to be honest with you. I think from the perspective of the staff, they all found this to be challenging. It was an opportunity. And because they were engaged in doing something that they thought would make their job easier or more successful, not fatigue, probably just the opposite, energized.
And how did the communication structure work? Was there, I know Carolina's led things, it sounds like interfacing with the nurses, some of the nurse management. Was Carolina the sort of voice of the changes? Was she the voice of refinements? How much of that was handled, so that communication process was handled by Carolina? How much of it happened sort of from others in the team?
It was a very iterative process. The 5 of us who I named earlier as part of the team would meet every 2 to 3 weeks, and our discussion typically was, okay, what has been our success with the most recent adaptations, and what are you hearing from the staff or seeing in terms of next steps? What do we need to be considering at this point? We do a little brainstorming and listen to the brainstorming that Carolina would bring back from the staff. So it was almost a continuous cyber loop.
Thanks. Questions from others in the audience?
Just a quick question about your SNP. Because we have a SNP program and we have about 1,500 patients, and we have an IOCP program with 1,200 patients. The job satisfaction in the IOCP program is so far greater than the job satisfaction of the SNP nurses. And I'm just wondering, all the compliance, regulatory requirements, the ridiculous care plan barriers and ranking and all the transitions of care. What are your strategies to continue to just support and increase the morale for your SNP team? Because we are just struggling with that particular piece.
Well, I don't know that I would say the morale has been that discouraging for us. they are very challenged by the behavioral health, the social challenges of the SNP population. And we've now gotten that new wave of the dual eligibles as a result of being in that 8-county area that's being piloted in Southern California. And compared to SNP, some of these dual eligibles are even another quantum greater challenge. So, you know, maybe the bright star in the sky is that if we can get enough of the SNP population into a plan, moved into an appropriate level of follow-up and monitoring, that they can start working with the patient, more of them will start working with the patient population that you would label your program IOCP. For us, it would be the MAs and the commercials, where the patients and their families often have more resources to support what's being done in terms of a care plan.
No, I found, you know, in answer to your question there, the stiff population is very difficult, and I noticed a real increase in morale when we added a social worker with the team, because she's taking that burden of us never being able to find resources for these people because they have the skill and knowledge. And I was just wondering if you had social workers embedded with your team.
We have one person who has a social work background, and Caroline has been manipulating the task assignments to try and make the best use of her resource. But I think we've talked regularly about the next edition. The next edition is going to be social work. And I asked that question about an LCSW doing any level of behavioral health work. We have a contract for our capitated patients with a behavioral health group in our area, and they do use LCSWs, and I'm trying to figure out what is the next step for our organization in terms of bridging. We have personal assessment, we've got very poor coordination and collaboration between medical health and behavioral health. So any step we make with this will have to be thought through. I think the team now does not need particularly an LCSW. I think that the greatest benefit would just be somebody who helps them with the kind of resource identification and linkage that a medical case social worker would offer.
So we found, you know, embedding an LCSW in primary care to be, what you end up doing is unearthing a whole area that we've known was there but ignore because we have no way of dealing with it. Is in primary care, you know, we can prescribe SSRIs, we can, you know, use PHQ-9 and diagnose depression, but the concept of moving people to a status where we're not just doing it for them, but rather having them improve and not need us so much, this is a requirement in this population. And for us, it's 40% of all our patients see the LCSW for therapy. So I understand the barriers to making a thing like that happen, but what we're doing is grossly undertreating the biggest problem we face and putting Band-Aids on things, which is nothing wrong with Band-Aids. You know, they help when you're bleeding. But, you know, it's not a transformational model to not have that, I think. And though I understand all the reasons why it's hard to make it work financially. So.
Thanks, Alan.
Yeah, great. Thanks, Dr. Payton. That was great. Tori, would you want to share some of your thoughts on your process?
Sure. So in my role with Sutter Health, I have responsibility spanning the continuum of care for case management. So I have both the acute side and the ambulatory side. So I have a case management, social services, palliative care, our post-acute care program, and I actually oversee the PACE program for a while. So My role was to try to bridge how we're actually trying to serve populations in the Sacramento-Sierra region. And I work really closely with our medical foundation, who actually has the grant element here. And to kind of give you the scale of what we tried to do and what we were up against, we have a 9-county region. We have about 270 primary care docs. We're serving about 350,000 patients in the primary care network. And I had 54 care sites. So trying to figure out how we were going to try to make that work over that span was what the challenge that we were trying to look at. And our organization recognized moving into the future that we were really going to have to look at population health management just like the rest of you are trying to do, and trying to do that in kind of this crazy world of being fee-for-service and having some risk patients. And the primary care physicians, as you know, don't think about payers, right? They're thinking about, I'm trying to take care of my people. So when you try to create programs that only deal with one certain segment of your population, it doesn't work really well. So we consciously went into this. We had a care management program since 1998. Primarily focused in on our managed care population. We made a decision 2.5 years ago to say, no, we're going to actually serve the whole entire population that our primary care physicians are working with, which really meant we had to redesign our model. And we had done a primary care patient-centered medical home model, and this is kind of classic in the value equation. We often do pilots that don't have a long enough period of time to allow the experiment to run its course to really understand and be successful. So we sunsetted that pilot at the same time and decided to take some of the learnings from that model and then put it into our existing program and redesign it. So our program consists of the RN case manager, LCSW versus just a social worker, a healthcare coordinator, non-licensed persons, and we added pharmacy into our teams. So the challenge was to try to how to take that model and then redistribute it amongst that such large geographic area and try to do that. At the same time, the foundation had an organizational goal around total care accountability, which was to say we're going to try to manage our entire population, so let's start to begin to focus at the top 2%. So really to do that, it meant changing the mindset of the primary care docs from production-based medicine, right, which is I'm just going to tackle my schedule every morning, right, because I'm full and I know that I got to do that, to really trying to say, how are we going to actually manage your entire population that you actually serve? So we really wanted to make sure that our program really became integrated within the care practices. And at the same time, our primary focus was to really support the providers so that they could learn how to manage risk in a population, which is a very different thing than they do right now. And so instead of just having somebody to refer off to, we wanted to really try to bring the program into those entire care centers. So when I hear the difference between deliberative and emergent, we have had to adapt as we've just gone along, as we've learned, because we have care centers that have 2 physicians in them, and we have care centers that have 30 physicians in them. So the model had to be adaptive to be able to do that. And we've also engaged in different type of contracting as we've gone along over the last couple of years, like all of you have, that as you get a different contract, you kind of have to shift and try to figure out using your resources to meet that contracting needs. And so we actually developed a risk stratification tool internally. I know that's kind of the pursuit of the Holy Grail, but what we did use that for is that we were able to bring to the physicians an example, and we did that by each of the care centers so that the docs could actually participate in the process of looking at what their panel and their risk of their panels looked like. And that was a really kind of pivotal moment, because it got them to start thinking about just doing my schedule every day, that I actually have a population that I need to manage and I have resources to help with that. And we adjusted our risk tool as we went along with that. And we just did another adjustment on it because it's never perfect, to try to be able to get to the place that we need to be. And so that process has been really helpful in developing that, and then trying to figure out how we can continually to spread the model that we're trying to make happen. So what we did is we've gone through and really looked at our population and tried to determine where the gaps were and trying to really figure out who is a high-risk population. And Alan and I were just talking earlier, it's a dynamic process, right? Our patients don't stay the same. They're kind of moving across the spectrum all the time. So how do you match your resources appropriately at the right time to be able to deal with the people that you need to be able to work with? And we also, even though we have a fairly large program, right, as far as what our FTEs look like and what we're able to do, but we're really only able to serve about 1% of the population. So the question is, if you only have limited resources, how do you shift those resources around? We also have some unique ways that our program gets funded, so we have to think about things that are actually important to the acute care hospitals, which of course is the transition to care work that we're trying to do. And so we've actually done some pretty good work. I think the engagement level of the physicians is higher than it's been before. And they're beginning to understand that we're actually trying to move towards this concept of population health management and what is it that they need to do that. One of the emerging things that we found is that as you start to do things for people, other people hear about it and then they want more, right? So all of a sudden the pediatricians were like, hey, what about us? We need some help too. So it's really interesting as you start to go through this process, you see more and more. And then it always is kind of fun that people always want the help, and then you go down to your place of like, well, do you want to pay for it? And that is a whole different discussion, right? So it's like, how do you craft that argument? And that's really what I'm trying to be able to put together to be able to make that happen. So how are we doing? So this is a graph that we use to try to look at. So what this graph is saying is that we know that we're targeting about 7,000 people would be considered our high-risk population, all right? And that's the red bar. And then what we're trying to be able to look at is how many people are we actually serving. So we're up to about 2,500 patients a month that we're managing. So we know that with our current structure, and I wanted to take some time to try to figure out what is the caseload that a team could manage versus an individual within the team. So we really try to take that team and say, how many patients can you actually manage? Because I think that's a better way to approach it. So we're coming in somewhere 350 to 400 maybe that a team can manage, we think, under what we're currently trying to do. And so what we can see is that we're serving a lot of folks, even if they don't meet the criteria of high risk, because about 50% of the folks that we are in our program don't quote unquote meet the risk criteria. Those are probably the rising risk people, right? Because when we started this, we told our docs, actually the chief of our family medicine said, you can change things, but you can't take anything away. So I don't know if any of you have ever been faced with that, like, okay, we have limited resources, we want to readjust how we're using our resources, we want to try to focus in on our high-risk populations, and everybody's supportive of that, but you can't let the docs not just refer whoever they want. So, you know, you talk about culture shifts, paradigm shifts, when you start to really say, I understand that this person is taking a lot of time and energy for you, but where do they fit in our criteria? So we're not totally there yet, but at least we're beginning to engage in the dialogue to be able to make that happen. And I think in a short period of time, we have used the lean methodology to do our implementation. I don't think we could have done this without doing that, because we literally go into, as we take this program into each of the care centers, we try to adapt it so that we're truly working with the care center staff too. So the transition of care work is the greatest example of that, meaning that our team takes the high-risk patients, but then there's a whole lot of other patients that still need to have the transition to care work done in a care center. So we've learned how to work together. So I think our goal of trying to get implementation has really progressed nicely. So where are we now? Like I said, I think our docs are better at the concept of thinking about population management and how they want to deal with their folks. That are actually causing them a lot of effort. We're really looking at how the team can actually really support the physicians in that endeavor. We've gotten better at understanding our population. I know that you're never totally there, but we know our people a lot better than we used to. And it's been interesting, as you take on different contracts and different payers will give you their list of high-risk patients, and then you try to compare them to your list. It's pretty fascinating to see how people make that decision and who fits into where. And so I think really what we're at now, it seems like we're always in budget cycle, right? Do you ever feel like you never get out of budget cycle? So we're at a point right now of, we've had good results. The practitioners love having the support. I know all of you recognize that primary care has definitely needed more support in order to be successful. And then we're just trying to see how can we actually spread this. So I think we've used some of the lean principles, which is go slow to go fast. Meaning that sometimes you have to really work out your workflows and processes, and then once you get them figured out, then you can move on a more rapid pace. So it's been a fun journey, and it's not done yet. And I think the challenge for all of us is to how do you make it work in an environment. For me right now, it's really the fee-for-service and the capitated market, and where are we going with that?
So I'm certainly very interested in the part where you said we decided to take our instead of just focusing on our at-risk contracts and open this up to our general population. Just as I know myself as a physician, I probably go to sleep at night and I've got those 3 to 5 patients in the back of my mind that I'm like, oh, these are the people that cause all my headaches, and I could use some help and support here. And I may have one or none of them that would qualify under our capitated market. So I'm curious as to what your percentage of at-risk contracts is that you cover so that you could open yourself up to that. I'm just thinking from our standpoint, if we opened ourselves up, we have a small market of at-risk contracts, and all the referrals that would come in would overwhelm it so that we wouldn't get any return on our investment, as that's been brought up. But from the physician buy-in side of it, I think it's brilliant. Just because to me that seems to be the engagement piece that's missing. Just so often people will ask us, say, this is a great program, can you take Mrs. Jones? And we say, nope, she doesn't meet this criteria, or she's not on her at-risk contracts. And so then they shut down and they go, well, fine, we'll never refer to you again. So we're trying to take the long view, right? And that if you're really gonna make a culture shift, you have to invest. And it takes a long time to make that happen. And I really do use the field of dreams analogy, which is, we have 2 choices. Either you spend the money now and build infrastructure, and how long it takes to get a case manager, build your teams, right? That's not like flip the switch. That you have to be able to put that into place and then take your contracts on. And at the same time, teaching your docs how to do things differently, right? Or you can choose to take the contracts on and then try to build your infrastructure out. You're going to pay one way or the other. So we're trying at least to craft an argument that let's invest for a long term. What is the response from those payers who are not in an at-risk contract with you and you're providing all these additional services? Does that open up any doors to negotiate with them, or do they just say, great, thanks for the extra money? And so you just bring up the lovely payer system we have. It's a really good point. So I think we take those one step at a time. We're actually, the new world that we live in now, that when the payers, in order to meet the ACA requirements, right, with all the criteria to actually participate and to come in at the price point, they've created all these high deductible plans, right? And now they're trying to figure out how are you going to manage those patients, because even though they're high deductible, they're still on the hook for those. So we're having really interesting discussions with the payers, and we just try to take them one at a time. And that's why we're trying to do this being somewhat payer agnostic, because the providers ultimately need to know just to say, how am I going to manage risk? And then we have the responsibility to create the infrastructure so they can do that.
I'm curious why you were saying that you had these 3-5 clients that kept you up at night and you're worried about, and yet they didn't qualify for the risk stratification. Can you give me just a hint of why they didn't qualify? Was it based purely on their insurance?
Yeah, so the ones that are the the rising risk that you referred to, we don't necessarily have a problem with those if they fall into our at-risk contracts. And they're the ones that, if we look at our triggers, hey, maybe they haven't been to the emergency room, or they haven't been admitted, but that's because I saw them every other day and had my nurse call them on the days I didn't see them, and we're managing some things. And so you see the writing on the wall, and it's like, well, sometime you're going to fall off the rails here. And we don't have necessarily a problem with those referrals and taking those people on, but we have structured ourselves to say we have very limited resources, and we're at a smaller market share of at-risk contracts compared to our at-fee-for-service contracts. And so it's mostly been that insurance portion of things that's kept us from making that leap. And once again, I'm like you in saying, yeah, when I'm have my physician hat on, I don't look at somebody and say, well, what's your insurance and what are we going to try to do with you? And I say, let's take care of you. It's like Pranav brought up saying, yeah, we studied beta blockers that they help in cardiac disease, and so you put on a beta blocker regardless. We just do the best thing. And so this is a new world.
Yep. So. I just wanted you to reinforce that, and I appreciate it. Thank you.
Go ahead, Brenda.
Okay, I had a question about the transitions of care, but we have like an episode, we don't enroll everyone, but if we have a physician reaching out to us, we will do an episodic intervention. And if it's a nurse or a social worker, we will make sure that that physician has that, intervention. So we don't necessarily enroll them, but at least we reach out to the physician to satisfy the physician for that patient, and we'll just do an episodic intervention. And that's been satisfying the needs for the payer sources that don't meet criteria. But my question was, can you elaborate on your transitions of care program and how you're fusing the clinic team with the care management team? Because that's really what we're looking towards doing.
Great. So we focus really heavily on transitions of care. Partly it's because we have an interesting funding model where actually the hospitals fund half of the actual care management program and the physician practices. So what's their benefit? So one of the big things, of course, is readmission prevention, when we know transitions of care are the kind of key to do that. So what we do is that, and my acute care case managers, the key to successful readmission prevention, right, of course, is follow-up care post-discharge. So we try to refer a lot of people to home health. We put a lot of people into hospice. We send people to SNFs. We actually have an advanced illness management program. So if those folks have gone off there, we consider that they're being managed, right? So it's everybody that doesn't fall into that category. Our care team then we have a report that comes out to each care center every day that lists all the admission, discharges, and ED visits. We scan that. We have a set of criteria that my team looks at it. And actually, it's the healthcare coordinator that looks at that and says, these are the high-risk patients, we're going to take them. And then the ones that are low risk, we give them off to the care centers. And we've worked and done the lean process of using that to build out the workflows. So that it's a combination of the Coleman model and then meeting the CMS requirements that are under, so you can build those codes. It's the logical stuff of making sure they have a visit, making sure that you're doing med rec, those kind of things, the phone calls.
Great. In the back, sure.
You said you're not managing your patients with individuals, but you're managing them as a team, and your teams can manage 350 to 400 patients? What does your team consist of? So our team, the primary model of the team is an RN case manager, an LCSW, and a healthcare coordinator, which is the non-licensed person. We use generally people that have baccalaureate degrees. BSWs work really well, sometimes LVNs. And then, unfortunately, I don't have a pharmacist on every team. I have 4 pharmacists that I try to spread amongst them. They focus primarily on transitions of care. So it's primarily those 3 folks. How many teams do you have that are sharing these 4 pharmacists?
We have 8 teams right now.
So I might ask sort of the 3 of you to answer something in short. It sounds like what we're hearing is a lot of this boils down to you from a position of leadership managing change, either managing change internally, improving upon something, or responding to external changes. Do you guys have like guiding principles that you come back to when it comes to managing that type of change? Is there something, sort of an attitude or philosophy or sort of a rules of thumb that you return to when it comes to managing that type of change?
Sorry, we were laughing as you put us in the right bucket. So our underlying philosophy is really trying to match solutions to the patient's needs. That helps drive no matter what the payer is, no matter how you slice and dice it, but it's matching really what type of interventions we can do to what they actually need. So that's what we use.
Great. Dr. Payton, any thoughts?
I think key word is anticipate. Try to anticipate what kind of changes are going to be demanded externally, and then anticipate that you have opportunities to change based on a better understanding of your own workflow, your own outcome and results, which is, I think, part of the reason for being very data-driven, that you need to be asking questions continuously. Are we getting what we planned for? Are we needing to plan for something differently?
Thanks.
I would echo those sentiments, and I would also say I think relationships matter. So your communication, your building of relationships, your stakeholders, because we're always in change. So having that group and constantly, I have learned you can never over-communicate. So the ability to spread your message relentlessly is important.
I wonder, so not all delivery organizations will have an inpatient part that will subsidize or contribute to building the team, right? So for organizations that don't have that luxury or the funder, how do you account for the costs of building the team? You're doing lean. That doesn't just fly on its own, right? It needs to have a lot of hand-holding, and it could be quite resource intensive. Are those implementation costs accounted for in your ROI calculation?
They have been for us. So we had such success in our Medicare Advantage capitated lives that what we did is expanded that model and framework when we addressed and came up with the enhanced care program for our commercial business. So we had to show the ROI continually. And to clarify, so our ROI also includes what we receive back from our total cost of care contracts. So we take a portion of that and take credit for that along with the managing it on an individual level. And then we set aside some of that money, and that continually goes back to building infrastructure. And then there's another pot that goes back to the physicians and part of their compensation in assisting in managing the populations.
So what's the sort of the combination of capitated versus fee-for-service population that you have, that you're able to use the gain from the capitated
So we have
contracts?
about 10% that's in full capitation, and another 50 to 60% that's at risk, some type of risk, and then the rest is fee-for-service, whether it's state programs or, but it's fee-for-service business.
Sure, Dr. Glazrow?
I'll just add to that. For us, the health plan and the global risk contracts is one way of looking at the funding. Our global risk has been managed two ways. With Medicare, we have kept the risk for institutional on a portion of our population and pay DRGs. So we get gain from reduced hospital admissions. A portion of the population that's under global risk, because of political situation in the community, the hospital got subcapped. But in negotiating the subcap rate with the hospital, there was a holdback of some of the money that they previously would have received under an institutional risk from the health plan. And we held back money to fund the care management program. Now, they're not keeping really close books on all of this, so it's going to be a challenge to either see those contracts change so that we really do get benefit of all of the cost savings on the global, or some other avenue of funding.
So what I would love to do is kind of look at all three of you together and kind of make a few thoughts, because I think what we're hearing is really valuable and important stuff. And you know, so we're hearing really creative use of data to sell worth when it's hard to make a purely, you know, dollars in the pocket argument, you know, from Phil. And I think that what you've done is brilliant. And in the narrow way you've defined avoidable cost, it's hard to criticize. Whereas if you had done it in a more loosey-goosey way, which I've seen out there, you know, it would never get past the CFO. I've heard Chuck say, and in an organization which, you know, what is it, every physician in charge, Beaver, you know, which is a physician-owned organization, that he has to do it contract by contract where it makes sense. And then I hear Sutter, you know, Tori, that they've made this long-term investment, but contracting is a problem, and because your costs are high, and partially as a result of doing the right thing. So you know, the sum of this is, I think, there is a lot of waste in healthcare. And where there is waste, and you know, it's to Ming's comment about lean, you can reduce waste, you know, through lean or by the work you're doing. You know, when a patient who is admitted doesn't have a discharge plan or appointment afterwards and gets readmitted without primary care having a chance to touch them, that's waste in a way, right? So you have people with waste on the one hand, and there's rampant waste across healthcare. We know that. There are also people of need on the other hand, some of whom waste is part of the problem, and some of whom waste is not part of the problem. They just are sick, right? And they're likely to cost more money as time goes on, and what you want for those patients is to spend more money so they have a better outcome. It's why we exist, right? And it's, you know, and I'm really impressed that Sutter's investing in that. In between, there's a sweet spot. You know, there are overlapping circles, Venn diagrams, and in the middle there are people who need you where there's also waste to be cleaned up. And I think depending on your organization, you can take on both circles. You can do a lean effort to fund doing the right thing in the other circle. You know, and you know, there's a great story out of Denver Health, which is a Medicaid health system in Colorado, and they did the right thing around this work, and they funded it by the savings they got out of lean. But it's not a physician-controlled organization, because in an organization like Beaver, that's profit out of the pocket of the owners, right? So I just wanted to frame that as, you know, the totality is these two circles. They overlap somewhere. Where they overlap, you can sustain a program. But the job is really to eliminate the waste so that you can fund the whole thing.
Yeah, really well put. Thanks, Dr. Gosdorf. That's it. I think did you guys want to respond to that?
Yeah, I just want to add one thing. When we were working with the Robert Wood Johnson Foundation on doing some quality and continuum of care work, there was a presenter one time who brought up a situation. She had been a CFO at a hospital. They built a parking garage. Once it was finished and people started to use it, they charged the employees like $50 a month. She said, guess who were the first two people in my office to complain? It was the neurosurgeon and the cardiac surgeon. But her point was in that, so this has to do with change, and I think we all have to recognize this with what we're up against, and her statement was, the more you have, the less you want to give up. So I always think about that when we're doing change management. We have a system right now where there are people that are doing well with it, and as we try to redesign things and shift around resources, you're going to hit resistance with that. So I've always tried to remember that, of like thinking of where your stakeholders are and where people are, and there's some inherent challenges that we're up against because of that.
Yeah, well said. Yeah, and I'll just reinforce what Dr. Gazarov said. Wonderful work, really great to hear about all the progress, impressive discipline and process. I think a lot of different challenges, finding that sweet spot in the Venn diagram and how the problems present sort of locally. But thank you so much for sharing with us, for popping the hood a little bit and sharing with the full group. And thanks for your attention, your participation. You'll join me in thanking our panelists. And